Thank you very much for joining this masterclass. One of the important differences in the new medical emergencies in eating disorder guidelines is that it doesn't just cover anorexia nervosa like the marzipan documents previously, but also covers other eating disorders such as bulimia nervosa, binge eating disorder, and eating disorders related to type 1 diabetes. I think this is a really important addition to the document because bulimia nervosa quite often is overlooked. It can be overlooked in medical education, and it's also often misunderstood in emergency situations. So hopefully we can spend a bit of time to explore these issues, what bulimia nervosa is, what kind of emergencies it can present with, and how best to help the patients both in a crisis and after a crisis. Bulimia affects not just young women, but also men, and across the age range. It is a serious mental disorder which has a standardized mortality ratio of 2 to 3. So the risk of death is 2 or 3 times as high as in age-matched population. In my clinical practice, I often find that even healthcare professionals, even psychiatrists can mix up bulimia nervosa with anorexia binge purging subtype. And in the current classification system, the main distinction between the two things is the level of malnutrition, so whether the person is below normal weight or not. And it's not that uncommon for people to develop bulimia nervosa after anorexia, which was initially recognized by Professor Fairburn in the transdiagnostic model. So I don't know whether you would like to comment on that, James, from your personal experience.
Yeah, I think the point about it not just being young women is really important, and that sort of means for people like me that people might not pick up on it or think that it's a possibility for somebody like me. And I think when I was anorexic with the binge purge subtype, people were very attentive, or more attentive, to my needs and to risk, because I looked really unwell and I had a lot of those risks from malnutrition. And then when I sort of just went over the BMI threshold, I still had a lot of the same problems with binge eating. So eating very large amounts of food over a period of time, maybe up to 2 hours. And then for me, purging with vomiting. And that people weren't perhaps so worried about me because I didn't look so unwell. And I think that it's interesting looking back on my experiences of many hospital admissions, say for low potassium, which I know we'll talk about later, but a lot of them happened sort of after I came out of these periods of being anorexic with binge purge subtype, and my weight was normal, but I still had these binging and purging cycles. And I think perhaps I had a low baseline of nutrition, but I looked well. And that's actually when I had the most admissions for low potassium. So I think that the big takeaway point for me, and what I would like clinicians to think about, is that it's not just how people appear. That's obviously very simplistic, but it's about, well, then what are the range of things those people could be experiencing, and what are the consequences, kind of irrespective of weight status, because I think that's a part of it, but it's not the whole picture. And I think recognizing bulimia as serious, and not just overeating a little bit and occasionally making yourself sick or finishing the packet of biscuits or whatever. It's pretty extreme, at least in my case. There'll be lots of different gradients of that, but it can be very life limiting, and it can have as many risks physically and psychologically as well. And I think that's the last point that I'd make on the contrast, is that very often with anorexia, I didn't feel as at risk psychologically. I was quite shut down emotionally and physically. And the sort of coming back of all those feelings and sensations in the body and the learning to regulate emotions again. That was something that happened after I'd gained weight, and that's when I was most at risk. So I think that has to be on the radar, that it's just as serious.
Yeah, I think it's a really important point that bulimia nervosa is an invisible illness. So it's not something that you can tell just by looking at a person. It can affect people across the BMI spectrum. The male-female ratio is higher than in anorexia. Adult Psychiatry Morbidity Survey compared with the 2019 Health Survey, there has been an increase of eating disorders in men under 40 by about fourfold. And that is not anorexia nervosa, it's probably bulimia nervosa and binge eating disorder. So this is an increasing problem. And I think we need to be mindful that quite often patients are underrepresented in specialist services. And one major reason for that is chronic underfunding, particularly of adult eating disorder services. So a lot of adult services use BMI as an exclusion criteria for access to services. And I'm aware that you've had difficulties yourself accessing services. And the other one is, I think, is stigma. So stigma both in the healthcare profession, but also self-stigma.
Yeah, and I think that they kind of lead into each other, because when you can't get access to care, it kind of tells you that you aren't really sort of worth it, or that it's kind of somehow your fault. And I think that those two kind of go together, the external and the internal stigmas. And I remember receiving a letter after being referred to eating disorder services saying I was too medically stable for the service. And that sort of really didn't sit very well with me, because I'd worked really hard to be medically stable. And then at the same time, I wasn't medically stable, because during that period, I was admitted with a stomach tear during that time that I was waiting for treatment, and still not able to access treatment for nearly 4 years in that instance, moving to this area that I'm in now. So I think that can result in a lot of self-stigmatization and also this feeling that you do have to cope alone, almost because that's your reality. So then when you do end up in an emergency setting where somebody's trying to help you and to intervene, you're not really used to it, and you're used to having to cope on your own, and so it can feel quite threatening and quite invasive, I think. So it's something that I think has to be like, something to bear in mind, really, in terms of the patient's experience. They might not be having the care that perhaps they should, and I've often been told in the emergency department, like, well, eating disorder service, of course, will help you to deal with the underlying problem. And it's like, well, I don't have access to that service, or sometimes that service didn't exist in the area where I was a while ago. So I think it's about recognizing the context isn't ideal, and then sort of not assuming that other people will be there to help. So thinking, well, what can you really do to help in that particular moment?
Yes, I mean, this is really difficult to hear, because we have good guidelines nationally. So we have the NICE guidelines, the NHS England Commission guidance, but many services struggle to implement those guidelines because of underfunding. Mm-hmm. And it is heartbreaking, because we have treatments which can help the majority of the patients. So hoping that this session will at least help raising awareness, and we will continue fighting for investment into services, so there is no discrimination based on BMI. The other thing which I noticed, particularly when I'm working with patients with bulimia nervosa, that there's a lot of misunderstanding even in the psychiatric profession. So often patients are missed or misdiagnosed. What you were describing, that with bulimia nervosa, people quite often experience significant emotional difficulties, and there is a bit of a chicken and egg situation. So quite often patients are labeled as personality disorder when they have an eating disorder which is treatable, and they might have other comorbidities such as anxiety, depression, or neurodevelopmental difficulties. So I think when people are seen in an emergency, differential diagnosis is really quite important in kind of deciding about optimal management.
Food and eating are such physical things that it's perhaps this work there for the mental health service side of things to get more interested in the body as well. But I think that it's not surprising that lots of other things could be involved. And for me, I was diagnosed with ADHD when I was much older than perhaps I could have been. But because it is sometimes quite difficult to see beyond the surface symptoms, I think eating disorders, in my experience, are quite sort of blinding in that that's all that gets seen rather than other things. And I guess it's kind of knowing where's the place to suggest that something else might be involved, and what expertise does the person have to do that, and how helpful would it be? But to also think about where you do have expertise and say the bodily basis of things like nutrition and metabolism, eating and everything, thinking what you can offer to that, because I found it really helpful to be informed about my experience, not in a way that sort of scares me, but when I've been sort of told and explained how the physiology works around binge eating, around vomiting, around potassium, around acid and this kind of stuff, I found that really empowering, and sort of it gives me some sense of hope that, okay, I could maybe manage that part. Maybe I can't manage the psychological bit so well because I don't have the treatment at the moment, but actually there is this part that I can work on. And ideally they both go together. And one thing that frustrates me the most is something I've heard time and time again in emergency settings of, oh, well, you need to address the underlying eating, almost as a way of sort of denying, not ever actually denying intervention at the moment, because obviously it saved my life many times, especially with potassium. But I think it's sort of this feeling of, oh, well, there's not really much point treating you because you need to address the underlying problem. And yeah, I was a revolving door patient for a bit of time in my life, but I still needed that, and perhaps they were right, but I think we actually need both. You can't just say, oh, you need to do the psychological work, because if you're not physically well enough, you can't do the psychological work. And it's the same the other way around. So I think that it's everybody seeing eating disorders and contributing to the health of people with eating disorders as their business is sort of my dream for the way that people with eating disorders are treated, whether that's at the dentist, at the sexual health clinic, at the emergency department, that everybody and whatever role they have in the team has something to offer to support somebody's health, with an eating disorder, even if it seems like this kind of really specialist thing that's somehow over there. Yes, those services should exist, but still everybody else can really help. And I've experienced that. I've experienced really wonderful help and support, and when things haven't gone so well as well. But I think that it's something, that's why I want to share, the things that have worked.
Thank you. I think for those people who are new to the field, maybe it's helpful to go into more detail what binging and purging means. Maybe if you kind of describe from your experience, and then I add some more. Yeah,
so I think my simple definition is that it's eating an abnormally large amount of food over a discrete period of time. So it'll be different for different people, but for me, it might be sort of eating for about maybe up to 2 hours until the feeling of being extremely distended and very uncomfortable and physically sort of in pain, but emotionally pretty numb, and kind of this function of sort of zoning out and not really having to feel anything, or not really having to attend to anything, and also not being able to reach out because it's kind of quite a sort of, it holds you sort of captive, I guess, and it's very isolating for that reason. You can't really ask for help when your mouth is full. So I think there's lots of wonderful metaphors about that, but it's this sort of quite intense behavior. And then afterwards there's some compensation, which could be through vomiting or laxative abuse or combination or excessive exercise. The idea being to sort of burn off the calories, as people often say, or for me, that sort of catharsis that comes with the exhaustion of vomiting is a bit of a relief. It's also, sometimes it's that emotional function for me, but other times it's very much habitual, or just being bored or not being able to put in alternative skills because it's very ingrained as a behavior. So it's not the same thing for everybody, but it's that sort of episode of binge eating followed by the compensation, and different ways of compensating have different risks as well. And one thing that really jumps to mind is dental health, which is something that I've been lucky to be able to be supported with really well, but I know it's almost impossible to access in some areas. And I think that bearing in mind that it's not just a little bit of food, and that is disabling in terms of time, in terms of money, because in order to get that amount of food, you might clear the cupboard if you're in a shared accommodation, have to go and replace it. If you're maybe hiding it, there's this element of secrecy that's obviously bound up with shame as well, and stigma. So I think bearing in mind sort of scale, I think, is the main thing that I say to people, and that it can be tens of thousands of calories, not just a little bit over, and kilograms of food.
And I suppose if we stay with the binging side of it, that can cause kind of gastric dilation, and can also kind of contribute to gastrointestinal bleeds, either due to the binging or the purging.
Yeah, so I for a very long time, it doesn't happen now hardly at all, but for a very long time I would vomit, and there would be blood, so it'd be red blood, and that was normal daily for years. And I would often have nosebleeds as well at the same time, but it sort of like would go away, would stop, and a lot of discomfort, and then feeling very uncomfortable with any eating, and feeling uncomfortably full, and lots of sort of I guess sort of, for me, in a non-medical sense, like agitation in this area. And I think the one time that worried me was when it was black blood, and I knew that was not a good sign from my limited medical knowledge. And so I went to hospital with that, and I ended up having an endoscopy, and it was a tear. They said, it's not very big, but it can be worse. There can be a bigger sort of perforation, or it could ultimately lead to a rupture, and not in a way that scared me, but in a way which actually that was a better experience that I had, because I found it very non-shaming, and that wasn't to do with it being necessarily a different incident. I was there for the same kind of reason, but it was the way that I was treated, and that's something I'd always highlight. It was in a really compassionate way that actively tried to sort of take away the feeling of shame that I had, because I felt like, oh, I'm wasting the resources here. We're all feeling now like we don't want to burden the NHS, and I was saying like, oh, I'm just so guilty, like I'm really embarrassed, and I felt it. And they said, this is not your fault, and it's something that you have experienced, and that has happened for whatever reasons. They really sort of helped me to feel like, okay, I can let go of that shame and try and move on. And that was actually quite a turning point for me in terms of recognizing that I wanted to look after myself, and that I was worth looking after. Because I do think these moments of crisis can be real moments of opportunity, and you can forge an alliance and a good relationship in a crisis. It's just sometimes maybe there are extra barriers. And I think that was an example of good care in a bad situation.
Yeah, I think that's really important learning point, that when people are seeing a patient with bulimia or any other eating disorder, and the attitude towards the patient really does make a difference. And then kind of recognizing that the patient will feel guilty and ashamed, and it's really important to be compassionate, and I suppose not end up stigmatizing or blaming the patient. And then going back to your previous point about too sticky, obviously, particularly with the current difficulties accessing NHS dentists, abscesses can actually present with life-threatening emergencies as well.
I had one before that was really bad, and my whole face started swelling up and my eye was closing, and it was really sort of dramatic, and had to have it drained in like an walk-in dentist place. It was quite sort of frightening, actually, and you just think, it's so close to my brain. What could happen? And I think that I would totally just agree with your point about not stigmatizing people. I have one thing that I find quite useful in terms of sort of how to think about it, instead of thinking that the patient is having difficult behavior or is being difficult, thinking that it's difficult for them, and recognizing that it's difficult for them, and actually communicating that, not I see this is difficult for you, and not seeing it as I see you're being like resistant, because I was extremely resistant and didn't want to go into hospital, would sort of not want to have treatment, and sometimes that would lead to having to call in a psychiatrist from another hospital, wasting time and resources to have an assessment, when actually other times when I'd had a good relationship and people had said, like, we know that you really probably don't want to be here and this is really hard, but we're here to support you, that actually meant that I didn't have to have the assessment, that I would agree to have treatment, and that I would feel like there was a point to it, and that it would help me to feel better. And I always did leave feeling better. And so I think that way of seeing it, that it's a difficult experience for everybody, actually, and not that the patient is being difficult. They just might be really frightened. They might be really sort of scared of that setting, might have had bad experiences before that we don't know about. And I think that being really compassionate about that, going back to the human skills, definitely not overlooking them. Even if you need to do a life-saving kind of intervention, it's still with care.
Yeah, I think that's a really important learning point around being compassionate and supportive, particularly if you feel that a patient is not accepting treatment, because by acknowledging the distress, usually you can find common grounds. I suppose the other kind of well-known consequences of bulimia could be related to dehydration or electrolyte disturbances. Particularly hypokalemia is a big and fairly common, unfortunately, dangerous consequence of purging, and not just with self-induced vomiting, but also with laxatives, or sometimes people use diuretics, so that can be really quite dangerous. With the hypokalemia, I think most doctors will know that patients will require IV replacement if the potassium level is below 2.5. And the patients may or may not actually recognize that they have hypokalemia. I don't know about your experience.
Yeah. So I never ever had symptoms of hypokalemia, and I think that I was told that I would be feeling dizzy and this kind of stuff, and I didn't feel that at all. I could never tell, and I didn't know the risks, and I thought, if I feel vaguely kind of the same, I'll be fine. But I was with very low, worryingly low levels of potassium, and being rushed into hospital every time I had a blood test. And I think that I didn't understand about hypoglycemia until a lot later on, which is surprising, really, considering that it's going to probably be involved. And I did have symptoms of dizziness and feeling sort of very lethargic, or even fainting, and this kind of stuff. But they didn't seem to correlate with the potassium. And when my potassium levels have restored, which they have been for many years now, I've still had those episodes until more recently, and not really knowing what they were was frustrating in a way, because I thought, it must be potassium, but I never had the symptoms before. And actually sort of informing patients, but also being aware of the different symptoms for different people, that there can be these different things going on, and that then can really empower them. Because the good thing about finding out that I was having hypos, which I unfortunately wasn't sort of helped really to find out about, even though I reported the symptoms, was that I could then manage it a lot better. I could learn about it and learn how to cope with it better. And people do want to get better; they just often can't see the way, or don't have the support to. But there is a role for physical health education, I think, as well. And then people can take it a little bit into their own hands, whereas it can feel very overwhelming if you're very unwell with an eating disorder to think, how on earth could I recover? And it's going to be step by step, and it might be one thing to manage in the physical health, one thing in the psychological therapy. But I think they can complement each other.
Yeah, I think the hypoglycemia is a lot less well known than hypokalemia or other electrolyte disturbances in bulimia nervosa, and I suppose it could be by different mechanisms. So one is about having hyperinsulinemia after a big binge, or it could be people kind of fasting for a long period of times. And you're absolutely right that it's important to manage that well, because it can be equally dangerous. Hypoglycemia is particularly dangerous if the patient has also type 1 diabetes and bulimia. And new MAID guidelines have a separate section on outlining the risks and the management, safe management for these patients. So I'm sort of thinking that maybe this is the time for me to share the Appendix 3 in the MAID guidelines. So this is an adaptation of the previous marzipan guidance. And as I mentioned in the introduction, the marzipan guidance was specific to anorexia nervosa. So in the new version, in the first column assessment, does the patient have an eating disorder? And if people working in emergency setting not sure, then it's always worth asking for a psychiatric review. And in terms of medical compromise, BMI, as we mentioned, is usually normal in bulimia nervosa as opposed to anorexia nervosa. But quite a lot of the risk indicators are on this list. So could be low blood pressure if people are dehydrated, electrolyte disturbances, abnormal liver function, hypoglycemia, abnormal ECG, which is usually related to the electrolyte disturbances and suicidal thoughts. We very briefly touched, does the patient consent to treatment? It's really important to encourage the patient in a compassionate way to consent to treatment, but obviously the mental health assessment may be relevant to some people. The refeeding column is not particularly relevant to bulimia nervosa in that checklist, but the management is relevant. And one of the key aspects is the medical and psychiatric staff should be collaborating well, or if that is not available, then psychiatric consultation should be requested. It's now usually a liaison psychiatrist. And it's important to think about are there any behavioral risks that might increase the risk during treatment. Probably most common would be in bulimia, kind of using further laxatives and purging. But then the risk of self-harm and suicidality can be significant as well. And it's really important just to note that we shouldn't be using BMI as a single risk indicator in eating disorders, and that's particularly important for bulimia. we kind of covered most of the physical risks associated with bulimia nervosa, and a suicide attempt or risk of suicide is significant. So that's something that we need to, I think we need to increase awareness of, because the current suicide assessment kind of methods don't necessarily consider eating disorders, particularly not bulimia nervosa, when people are kind of talking about risk, and that is really quite important as an opportunity to recognize the underlying issues for the patient.
Yeah, I think it's important to consider, not just to see the eating disorder, to consider emotional distress, but also the thing with bulimia, just from my own experience, and it might not be the same for everybody, is that when I have felt more suicidal, it's been a moment where the bulimia has sort of stepped in almost to safeguard me. So instead of thinking about sort of suicide or how that might happen, the binge eating can then sort of cut that off, and cut off that train of thought and actually make me safe in a way. So it's sort of been in an emergency context, kind of I've wanted to go, if I felt suicidal, I've wanted to go, not necessarily with the aim of ending my life or attempting suicide, but I've wanted to go and sort of use the behavior to sort of take that feeling away, and that's not available in the emergency setting. And so that function, which can be many and varied, is kind of something I'd emphasize, and it can change over time, but that function of perhaps sort of cutting off those feelings that might be associated with suicide or those thoughts, I think is important. And to perhaps think that if somebody doesn't have those behaviors to hand, whatever their eating disorder is, then they're not getting the benefit of those eating disorder behaviors, which sounds a funny way to put it, but the function of them, is for a reason. And so they might feel worse if they can't use those eating disorder behaviors, whatever they are, including bulimia. So I think that it does relate to, intense distress or suicidal thinking as well. And just thinking that this person's in a very difficult situation and they don't have their normal way of coping. So no wonder actually it's going to escalate the risk that they would perhaps have psychologically.
And I suppose that kind of leads us on to the importance of aftercare following an emergency episode. I think we all should be a lot better at this. And certainly in my own clinical practice, I often find out from the patients that they've been to an emergency department rather than having a direct kind of communication from the emergency department, or the GP may not be aware of the escalating risk. Bulimia nervosa has good treatments in our national guidelines. I would kind of advocate that those patients who are in a crisis, who require intensive emergency treatment, would really need to be prioritized, even in services where there are lengthy waiting lists, because people don't get better by themselves. So prioritizing patients and offering appropriate treatment depending on their individual severity, but also their comorbidity, can make a big difference and prevent, I suppose, repeated emergency presentations.
Yeah, I would say that if I had an ask of people working in emergency departments, it's sort of, if you can flag it to other people that this person needs the intervention, whether it's writing it to the GP or suggesting actively that they should be, prioritized if they're presenting in emergency departments. I think that would be really helpful. I know that when I was able to access specialist treatment after nearly 7 years, I didn't have hospital admissions during the whole time I was in that treatment, and it saved money in some ways, and it can help, I think, people get the support that they need a bit sooner, because the good news story is, of course, that people can get better, and people do get better, and directing them to the help, the specialist help that's needed, and helping them in a crisis are all really important parts of the puzzle.
Yeah, well, thank you very much. I think we probably covered everything.
Yes.
Anything you would like to add?
No, I think I finished on my sort of request.
Okay.
Yeah.
Okay. Thank
Thank
you.
you, Agnes.